Hello, my name is Dr. Kieran Docherty. I'm a clinical research fellow at the University of Glasgow, and the title of this analysis was the effect of dapagliflozin on outpatient worsening in patients with heart failure and reduced ejection fraction, a pre-specified analysis of DAPA-HF. So in DAPA-HF, the SGLT2 inhibitor dapagliflozin compared with placebo reduced the risk of cardiovascular death or worsening heart failure and improved symptoms in patients with heart failure and reduced ejection fraction, or HFrEF. Now, clinical trials in heart failure have traditionally focused on the endpoints of mortality and hospitalization for heart failure. However, in the recent years, there have been increasing efforts in clinical practice to reduce the rate of hospitalization by treating worsening heart failure outside the inpatient ward setting. And this is reflected in the inclusion of outpatient episodes of worsening heart failure treated with intravenous treatment in the primary composite endpoint in DAPA-HF. However, as trials such as Paradigm-HF and DAPA-HF have demonstrated, which have collected information on these events, they are relatively infrequent. And an event which occurs much more frequently than the outpatient use of intravenous medications is augmentation of oral heart failure therapy in the community in response to signs or symptoms of worsening heart failure. However, such episodes have not been routinely recorded in clinical trials. Therefore, the frequency and prognostic implications of these events is unclear. So we collected episodes of outpatient worsening requiring the intensification of oral heart failure therapy routinely in DAPA-HF. And the aim of this analysis was to examine the frequency of these episodes, their prognostic importance, and the effect of dapagliflozin on them. So all 4,744 patients who were randomized in DAPA-HF were included in this analysis. And we compared the effect of dapagliflozin with placebo on a pre-specified exploratory endpoint of time to first occurrence of cardiovascular death, hospitalization for heart failure, an urgent heart failure visit requiring use of intravenous therapy, or worsening heart failure symptoms or signs leading to the initiation of new oral therapy or the augmentation of existing oral treatment. So in other words, the primary composite endpoint of DAPA-HF with the addition of outpatient worsening events requiring intensification of oral heart failure therapy. And investigators were asked to record outpatient intensification of heart failure therapy on a specific case report form in response to the following questions. So was there outpatient intensification of heart failure medication due to worsening symptoms or signs of heart failure? And if so, was the dose of diuretic increased and sustained for a month, or was a new drug added for the treatment of worsening heart failure? And we examined the relative hazard of death following a first non-fatal manifestation of worsening heart failure, considering each event type as a time-updated covariate. So 1 in 4 patients in DAPA-HF experienced at least one non-fatal or fatal manifestation of worsening heart failure during a median follow-up of 18.2 months. Compared to patients who experienced no worsening heart failure event, patients experiencing any form of worsening heart failure were in a higher, i.e. worse, NYHA functional classification, had a lower left ventricular ejection fraction and systolic blood pressure, higher levels of NT-proBNP, and a greater degree of renal dysfunction. They also had a higher prevalence of atrial fibrillation and diabetes, and were more often compared with diuretic and digoxin compared to those with no worsening event. And these trends were generally consistent across each non-fatal manifestation of worsening heart failure, but were not as clear for cardiovascular death, where conversely we saw that an ischemic etiology was more common compared to other patients. Now, as demonstrated by the primary analysis of DAPA-HF, the primary outcome of cardiovascular death, heart failure hospitalization, or an urgent heart failure visit was reduced by 26% compared with placebo, with a number needed to treat to prevent one event over a median follow-up of 18.2 months of 21. When outpatient worsening events requiring intensification of oral therapy were added into this composite endpoint, the magnitude of treatment effect was similar, with a significant 27% risk reduction and a number needed to treat of 16. Furthermore, when we looked at each individual component of this expanded composite endpoint, dapagliflozin reduced each component individually. And when we examined outpatient worsening events requiring intensification of oral therapy as a standalone endpoint, 1 in 8 patients had at least one of these events during a median 18-month follow-up, and dapagliflozin reduced the risk of these events by 26% compared with placebo. 20% of patients who had an outpatient worsening event had a further fatal or non-fatal manifestation of heart failure during follow-up. After adjustment for prognostic features at baseline, the risk of mortality in these patients was threefold higher compared to patients who had no worsening event during follow-up. This risk increase was a similar magnitude to those patients who had an urgent heart failure visit requiring intravenous therapy. And we found in patients whose first event was a hospitalization for heart failure, their risk was sixfold higher than patients who had no event during follow-up. So I think the main findings from this analysis are that episodes of outpatient worsening requiring the intensification of oral therapy are common, affecting 1 in 8 patients during a relatively short, median 18-month follow-up, and they're also prognostically important. And I think that this highlights that despite excellent contemporary background pharmacological and device therapy, patients with heart failure and reduced ejection fraction still experience a high residual rate of worsening heart failure requiring intervention. And importantly, the risk of these events was modified by treatment with dapagliflozin, with a 27% reduction in risk compared with placebo. This finding extends the evidence that dapagliflozin has an incremental benefit in patients with heart failure when added to guideline-directed therapy.